Dear colleagues, it's a pleasure for me to present to you in the next 10 minutes the lupus signature from type 1 interferonopathies to COVID-19 acro-syndromes. Thank you to Professor Aline Tatu for inviting me for this lecture in Galatz. I'm sorry that is only by video. So these are my conflict of interest and no conflict of interest to declare for this presentation. The learning objectives is to make an overview on an autoimmune disease with features like lupus erythematosus, to focusing on immunity's key upregulating factors like interferon type 1 expression and of the consequent vascular lesions found in different diseases, including COVID-19 acro-syndromes. At the end of this lecture, participants should have a better understanding and an easier investigation plan for what is linked to interferon type 1 overexpression from lupus and lupus-like signs and symptoms. First of all, on lupus erythematosus and lupus signature. We know that it's an autoimmune disease with the genetic, immunological, and environment factors, but the clinical and pathological features of lupus have common elements with several systemic auto-inflammatory diseases. We know that the dermal epidermal lupus has a systemic involvement. The dermal lupus, the typical like tumidus, is with a possible systemic involvement. Subcutaneous lupus, like panniculitis, it has a possible systemic involvement. But neutrophilic lupus, like urticaria-like, also has a systemic involvement. Here is one of the keys of the take-home messages from today. The vasculopathy and thrombosis is giving chilblain lupus, livedo racemosa, purpura, and other features that we will see together, and the different other vascular impact like Raynaud's phenomenon. We know everybody that autoantibodies are typical for lupus, but type 1 interferon is important also in lupus erythematosus pathogenesis. The autoantibodies are from different families, and the immune complex deposits are found in the skin, in synovium, and in kidneys and in blood vessels. The type 1 inducible transcripts and chemokines are highly prevalent and in blood and in tissues in patients with systemic lupus. And also there are other proofs that type 1 interferon administration in humans can induce systemic lupus erythematosus symptoms. And the key elements are systemic lupus erythematosus autoantibodies, complement 3, and type 1 interferon inducible chemokines, which are part of the common lupus signature. The measurement of the type 1 interferon expression could predict the subsequent disease activity of lupus activity course, and this was published last year. I tried to simplify the mechanism of lupus that you know very well with the activation of the lymphocytes, the TCD4, and with the activation subsequent of the B cells with autoantibodies. And here is appearing the type 1 inducible chemokine, and we find immune complex deposits at the dermoepidermal junction in dermatology, but also type of vasculitis in different organs and diseases. In histology, we see this vasculitis, and in chronic lupus along the dermoepidermal junction, we have this granular pattern of deposits of IgG, but there is a microvascular thrombosis in acute systemic lupus erythematosus. The common lupus features, I will not insist because you know very well the acute, the subacute, and chronic discoid lupus erythematosus, but also you have other lupus features, don't forget, like pseudo-urticaria, like tumidus lupus, like lupus panniculitis, and sometimes annular lesions like lymphocytic infiltrate of Gessner and Canoff. The vascular features of lupus are livedo-like, Raynaud's phenomenon, sometimes pseudo-Degoss disease in systemic lupus erythematosus with dyspapules, atrophian papulosis with porcelain center. And vascular features of lupus are also presenting pseudo-chilblain lupus, which is a microangiopathy in children. Chilblain lupus is also present as an acro-syndrome. What about the type 1 interferonopathies? This is part of systemic autoinflammatory disease, SAID. Interferonopathies are proteins which are regulating upregulating the type 1 interferons, and they can induce systemic lupus erythematosus or other syndromes like Aicardi-Gouttière or Singleton-Merten, or you will find many of these syndromes on the literature. Inflammasomopathies are also part of SAID, but also immune proteinopathies. We don't have the time to focus on this. Immunoactinopathies and also relopathies. I tried to simplify all these mechanisms of systemic autoinflammatory diseases, where number one are interferonopathies, but also inflammasomopathies, deficit in ADA2, activate TNF alpha receptor, passing through NF-κB, mutations within the endogenous antagonist involving interleukin-1 receptor, endoplasmic reticulum stress with the entrapped syndrome. Actinopathies, of course, are part of the systemic autoinflammatory diseases. But what is happening if you see a patient with a livedo, with thrombosis, with fever, but no infection, pyoderma-like lesions, or acral skin ulcers in young people, mainly stroke, family cases, apoptosis, or sweet syndromes, or other neutrophilic dermatosis, some joint pains, and C-reactive protein regulated. These are what we call alarm bells for systemic autoinflammatory diseases, and including for interferonopathies. So in type 1 interferonopathies, the alarm bells are chilblain-like vasculitis, interstitial lung disease, and molecular and biochemical interferon signaling. What is happening if a virus, including SARS-CoV-2, but other viruses, can induce cell death, will release a self-DNA release. And this will induce in different types of cells, dendritic cells, lymphocyte, monocyte, interferon type 1 expression. So the main diseases in this class of interferonopathies of type 1 are 13 diseases today. One of the most known is systemic lupus erythematosus, monogenic forms. What about the third part and the last part of my topic, COVID-19 and interferon of type 1? In COVID-19 patients with lupus-like lesions, mainly with chilblain-like or acronecrosis, you can have the RT-PCR test for SARS-CoV-2. You can find positive, but you can find negative tests. But the negative test must not exclude the relationship with the COVID. Why? Because the viral absence in skin lesions like pseudo-chilblains is due to an efficient response to type 1 interferon. So you look for the virus, but it might be already gone because it was chased by a good interferon type 1 response. An article published by a French team from Nice, south of France, showed that in 40 patients with chilblain-like lesions, none had positive RT-PCR test for SARS-CoV-2, and 12 out of 40 had positive COVID-19 serologic results. But they looked further and they found significant interferon type 1 response compared with patients with PCR positive acute COVID-19. So what you can see in patients with chilblain-like lesions, you can see images of vasculitis and IgM deposits, like here in green in immunofluorescence, but also this vasculitis. In severe cases of acral syndromes in COVID, you will have much more things, lymphocytic vasculitis and retiform purpura in lesions with severe COVID. And you can see here fragments of the virus, but even the virus with my white arrow here, this was published in British Journal of Dermatology 2 years ago by a Spanish team, and it's a very interesting article. We published in the Journal of American Academy of Dermatology a series of 277 patients with chilblains, where 53% were SARS-CoV-2 positive, or they had extracellular COVID-19 symptoms, or they were close contact with COVID-19 patient, or both. In a bigger series of 375 patients with COVID, only 41% of patients were SARS-CoV-2 positive. This was a Spanish series. In a larger series with an epidemiological analysis published in JAMA Dermatology last year, in a series of 780 patients with chilblains during COVID-19, where only 456 tested, only 26% were SARS-CoV-2 positive. The serology test results, only one was positive out of 97 tested. In a French series with 492 patients with chilblains during COVID-19, 51% have COVID-19 symptoms, but RT-PCR was made only in 30 cases and only one was positive. So we can conclude that this kind of feature with chilblains-like, with minimal vascular damage, with good interferon-1 response, and this will mean absent or minimal viral load. So these are pseudo chilblains. But if you see retiform purpura or acronecrosis, this means that it is a more severe COVID-19, and you will have major vascular damages, and you will have a lower or no interferon response, and you will have here an important viral protein load. You will find the virus here. So we can conclude at the end of this lecture that the dysregulation of the interferon pathway induce specific, what we call interferon alarm bells, systemic lupus erythematosus, or lupus-like lesions, chilblains, livedo, necrosizing vasculitis in more severe cases, paniculitis, familial idiopathic juvenile arthritis resistant to treatment, non-infectious interstitial lung disease, and also chilblain-like lesions during COVID-19, what we call vulgarly COVID toes. Don't forget that next year in July 3 to 8, you will have a huge Congress, World Congress of Dermatology. It will be very interesting to participate in this big Congress in Singapore. This is my hospital some 400 and some years ago. This is my hospital today, still standing and still good looking, and with a new part of the hospital where I work. I put here some names of the diseases that were the names of the dermatologists working at the St. Louis Hospital in the last centuries. Mulțumesc foarte mult. Thank you so much for your attention.